Thank you, sir, for giving me this opportunity. I'll be talking on intervention strategies for symptomatic vitreomacular adhesion, surgical or ocriplasmin. My talks are essentially on the basic concepts which lead to developing the strategies. It's important for all of us to realize this International Vitreomacular Traction Study Group classification, which defines clearly what is vitreomacular adhesion, vitreomacular traction, and vitreomacular and macular hole formation. I'll show this to you more pictorially. This is what it is. So vitreomacular adhesion, based upon the international classification, these are certain criteria, and it's important to know this definition of drci.net, which defines the zones which we get on the OCT, because all these we have to have ways of calculating. So there is an evidence of perifoveal vitreous cortex detachment from the retinal surface, which you can see here. There is a macular attachment of the vitreous cortex within 3 mm radius of the fovea. There is no change, as Dr. Malika beautifully pointed out, no change in the foveal contour. So if you have a situation like this, you can call it a focal vitreomacular adhesion or a broad focal vitreomacular adhesion based upon the area to which the vitreomacular adhesion is there. The next is the vitreomacular traction, and the only difference is between that definition is an evidence of foveal surface distortion, intraretinal structural changes like cystic spaces, surface irregularities, or eventually leading to formation of a macular hole. Again, you can have a focal VMT or a broad VMT. It's extremely important because all this is based upon physics which is going within the eye. Macular hole IVTS classification, you can have full thickness macular hole. This disrupts, the definition is disruption of the retina from the ILM to the RP. Now, according to the size, it could be small, which is less than 150 microns, 150 to 400, which is medium, and more than 400, which is large. The cause could be primary, when you can demonstrate an element of traction, or it could be secondary, like a primary pathology of the macula, or traumatic in nature. A lamellar macular hole, one of the basic concepts is photoreceptor layer is maintained. Or you can have a pseudomacular hole, which is invagination of the heaped foveal edges, ERM with a central opening, as Malika showed a picture, maintains central foveal contour and no loss of retinal tissue. Now this slide I'll spend a little time, which is important for you to understand. What is stress on retina? Stress is force which is applied to the retina divided by the area of attachment. So if we have a force which is in form of, which we calculate as newtons, and the area of attachment which has come from a study is 1828 microns, this is situation A. So you have a amount of stress based upon the force. Now, as if the force remains same, but the area of attachment reduces, the stress increases, which is very simple. You go to the next stage where the force remains same, the area of attachment further reduces, the stress increases. Therefore, if you have a broad-based attachment to the macular surface, the stress upon the retinal surface is less. That's why we find that people who have a taut posterior hyaloid, who have a large ERM which is flat and tightly adherent to the macular surface, does not lead to cystic changes. Why? It is because of this fact that the stress because of those membranes is minimal. But if you have a focal attachment which is not very broad, it causes, with the movements of the eye, and if we go to the laws of physics, which is whenever the eye moves and the eye becomes static, the vitreous is still moving. When the vitreous is still moving, the traction is going, the eye suddenly turns left, the vitreous has to suddenly turn left. So focal attachment in this area leads to macular edema. Now, Malika showed before that if there can be, now strategies are either there can be a natural history of resolution of vitreomacular traction, which is extremely nice, so we can follow up these patients, or we then can go into various indications. One is ocriplasmin. Now this is a truncated form of human serine protease plasmin. It targets the major components of vitreoretinal interface. which is fibronectin and laminin, which produce the vitreoretinal separation and vitreous liquefaction. I will spend a little time on the MIVI Trust study, which basically is based upon the mycoplasmin for vitreous injection and traction release without surgical treatment, and has been a pivotal study for VMT and macular hemorrhage, macular hole. So this is how oculoplasmin acts. Basically, it causes liquefaction of the vitreous and separation of the vitreous, and that is because it acts on fibronectin and laminin and causes breakdown of the collagen fibrils, and that is how it helps. This is a study which was initially done in mouse, and then it went to the stage of human. And this is a case which represents how at various stages, it takes a little time for patients to respond. And this is a patient who is a 58-year-old female who had oculoplasmin injected and did not have an ERM, and gradually the traction settled down. So MIVI Trust data basically showed that 30% of oculoplasmin treated patients showed resolution of VMA by day 28 compared to 8%. So this is important to remember that between the 30 and 80, it's actually only 22% patients who responded to oculoplasmin. That means 8% placebo treated patients also responded. If we take the responded patients who responded, 41% of them had 2-line improvement, 14% 3-line improvement, and 70% resolved in 7 days and 100% in 28 days. The macular hole subset, 58% of the macular hole closed in 28 days, 25% which is more than 250 microns in 28 days, and 11% macular hole closed even with placebo injections. This is the commonest symptoms which they had was vitreous floaters and eye pain, and there are multiple other symptoms. For lack of time, I'll not go into it. Now, this is the way a macular hole would. So, initially, you can have a broad attachment, leads to a focal attachment, and if you don't intervene here, what happens next? 3 months later, a macular hole forms. Now then, you have to do a surgical repair and it gets closed. So either we can intervene here when we have a focal attachment, or we have to then intervene when a macular hole forms. This is the situation, as I said, a broad base attachment, converting your focal attachment is an indication for surgical intervention. These are some of the examples of intervention, how they responded. And I'll quickly then show you some videos. And see here, there's a focal attachment. You can't let it be like this. And it's a very simple surgery. The question here is, if you are able to take off, remove this attachment, it's well and nice. In case you have an ERM, sometimes you can truncate the ERM at the apex, leave it there, and the retina will settle down. These are some of the examples of macular hole closing. These are some of the examples. This is one patient, another patient, how they responded. This is another situation. Now, this is an example of how, this is a small little video clipping where PVD is being created, and you can create with the cutter itself. We go into different quadrants, make sure that you have done 360 degrees, and then it becomes a very easy task. This is a situation where I actually do not directly do with the forceps. I create an edge with a bent needle. Somehow I have a fascination for needles, so I prefer that, and then we go ahead and peel off the ILM. So it's important to remember here that if you do a brilliant blue staining, you can have stained areas which will be represented by the ILM, and unstained areas which is a sort of a negative staining. So when you peel off the ILM, it works out extremely well. We'll go to the next video. This is with the brilliant blue staining. We remove the excess stain and then go ahead and maybe I can push process it a little bit. Create an edge and then you remove the membrane. It comes off extremely well without any problems. So that's the concept. Go to the next stage. This is anyway. So here is a situation where I want to point out this patient refused intervention. And this patient was followed almost for a year. So sometimes these membranes can remain stable for a long time, where a surgical intervention is not required. Do not force surgery upon the patient. So, for surgery for vitreomacular adhesion, it's important to differentiate between VMA and VMT. A symptomatic VMA, reduced visual acuity, metamorphopsia, progressive visual deficit, and alteration foveal contour must be handled. Strategies for management of VMA: PVD induction and gradual hyaloid separation. If the fovea is dented, trim the hyaloid membrane around the fovea. If the ERM is tightly adherent, beryllium blue assisted ILM peel. The areas of ERM presence is recognized by negative staining of beryllium blue. I wish to just bring to your notice, this is for the first time. Actually, these are the valve cannulas which I have made. These valve cannulas are now being introduced in this conference. These are autoclavable cannulas, the autoclavable valves, and it really is, it does wonders. Initially with one bottle, we used to do, one bottle will finish off with one case. Now with one bottle, I can do 3 cases. The fluid movement is less. Now this patient had, you can see this is a special faucet which I have designed to load the cannulas. Now once you have to do a soft tip cannulas to go in, you can remove the valve and do the surgery. And for this situation, you can even put a plug inside this, so it works beautifully. You have a valve, you have a plug, and the fluid dynamics become extremely useful. And in cases like this, it really helps significantly. This is silicone oil being inserted, and anyway, so thank you for your kind attention.